As a novelist, I create many characters. Turns out these characters have to have jobs, if I want to make three-dimensional characters. And I've been able to, they say write what you know. I've been able to use some of my own work experience, just about all of it, really. Landscaper, caregiver, hot dog vendor. Eventually, I tend on using telemarketing. But my I have a vast array of characters. I need specialists in these things. These jobs that require specialization, um, I have to interview people for my book. Just so I can't hit any false notes. You hit any false notes and, you lose the reader. I've interviewed cops, EMTs, parole officers, insurance salesmen, dentists, rangers, train engineers, you name it. And I go through this process with people. And usually how I do this is like, I got a ton of Facebook followers and friends and so forth, and I just crowdsource it. I'll go, "Hey, does anybody know anybody in this profession?" And that is how I came to today's guest, Lexi. Lexi is an ER nurse, and I interviewed her for my novel in progress. And when I was on the phone with her, taking mad notes, I mean, I found her to be so interesting and so candid that I was like, at the end of it, because we're always looking for podcast guests, me and Jason, and I'm like, I should just interview her again for the podcast because I've been wanting to do this for a while, like interview people with cool jobs because I'm fascinated with it. But before we get to Lexi, just a little bit of a little bit of housekeeping. Subscribe to the newsletter, people. You'll get access to very special content on the Substack. You get the newsletter every week. It's free so far, so take advantage. Get in on the ground floor of the newsletter. You'll find the link below the pod. And okay. As you were, I just wanted to remind you. I often forget to do that. So today we're going to get the inside scoop from an ER nurse, Lexi, who's going to provide us with a little inside baseball look into the behind the curtain of a busy urban, emergency department. Please welcome to A Fresh Face in Hell, Lexi. So, Lexi, thank you for joining us on A Fresh Face in Hell.
Good morning. Thanks for having me on. Happy to hang out.
I know we're going to have to work around HIPAA concerns and, we've got client provider, confidentiality and things like that. So we don't have to name names. In fact, I'm not even going to ask you the name of your hospital, but could you characterize your hospital for us? I mean, where it's at, the environment and so forth.
Yeah, so what makes it slightly better is that I've worked at several hospitals in the local region. So some of these stories are from different hospitals anyway. Even if people do know where I work, they know where I've worked. They don't know which one it is. It's harder to find your people, right? So I live in a larger area, suburb of a large city. There's 3 or 4 different hospital systems in the area, and I've worked at 2 of them at various locations. I've had standalone emergency departments as well as smaller emergency departments, like 20, 25 beds, and then larger facilities, more beds than that in the ER.
It's always a monkey house in the ER. I mean, I've wound up in a lot of ERs, and it's always a madhouse, which is one of the reasons I was so excited to talk to you about it. Because as the patient, I mean, you get a little glimpse of it once you leave triage, and they take you back to a bed or something like that. And I'm always kind of walking through, trying to soak up as much information as possible on my way there. But I'm very curious about how it works and hospital dynamics and stuff. I guess where I'd want to start is, can you just kind of walk us through your day from like the minute you pull into the hospital parking lot or whatever? I want to get a sense of like how soon the madness begins.
Yeah, well, finding parking is the first spot of madness. You scroll through all the lanes trying to find spots that are marked so employees can park there. Some of our facilities require us to pay for parking. Other places have free parking. Once you manage to sneak a spot out of somebody who's leaving, then you hop in the break room. Most places provide scrubs to some degree. So you go and you change in your break room and head on up to the floor and you jump right in.
And for the
So
scrubs, I see sometimes I'll see a lady in like Smurf scrubs, or
mhm.
but I mean, I do you to add flair like that, or do most hospitals be like, look, we just want the kind of classic white or green?
Yeah, it depends on your facility. If you're in an OR facility, like if you're anywhere that's going to end up in the operating room, you got to wear operating room scrubs. They're sterilized by the hospital. Other places launder their own scrubs just so that they know everybody's safe and clean. And most places allow for you to wear whatever it is that you want, scrub style wise, but some of them do require it. If they require it, though, they have to pay for it. So that's why most places probably don't pay for it.
See, I'm already
They
hitting you with the
yeah.
hard-hitting questions, the hard
Yeah.
journalistic. Tell me about the scrubs. Okay, so you get it to the what you call the break room, locker room. Um, People have their lockers decorated oftentimes, right? They're the kind of little home away from home. They keep their lunch in there, maybe or whatever. Uh, and then
Extra shoes, extra scrubs, shampoo and conditioner, and body wash because you don't know what you're getting on you that day, so I've more than once needed to take a shower at work
oh, well,
mid-shift.
having heard a few of your stories, I can guess at a few things you would have on you. We'll get into that one later. Whew, man, that would
Yeah.
give me nightmares. Um, so, when you go from the break room and you hit the hospital, I mean, I can't just it just must be like sensory overload right away, just like beep beep beep. The doctor, paging doctor, we got a code blue
Yeah.
over here. I mean, it just
Yep. Overheads, fire alarms, generator testing, codes, rapid response, and then there's periods of time where there's nothing happening, right? Like, there's and you're just, like, waiting for the other shoe to drop, but, yeah, generally, you walk in and you've got 2 alarms dinging that ding continuously during your shift, or you've got, you know, somebody's yelling from the corner. I know we've all seen those on, your For You page or your Instagram Reels or wherever it is that you watch your little shorts, and there's just, like, yelling and screaming from one side and dinging from the other side, and somebody's asking you a question, and yeah,
so because
that
the
starts
psych
right
ward
away.
is always nearby, and a lot of the patients in the ER are going to be. I was in Haight-Ashbury Clinic once for a drug overdose. Well, I was just having a bad trip on LSD. This is like 30 years ago.
This is not where I wanna be.
Yeah, well, sometimes you've been assigned to the psych ward and you get throttled once.
Yeah, I've had 2 episodes where I've had a patient strangle me at work. One was about 10 years ago, and the other was about a month ago. I've been spit on, hit, slapped, kicked at. We're people that should probably be arrested are often sent to us for medical clearance, which is fine, except that it's like me and 3 other people. I'm 5'3" and about
Right, and you don't have a
120.
taser, like a cop has a
I don't have
taser, so, yeah.
anything. I have a B-52 shot if I'm lucky, and that's about it.
So we're just walking in, and the first thing is, like, there's a like, a shift change, right? You guys have some kinda huddle or, like, how does that work?
Yep. Yeah, so most places do a morning huddle and an evening huddle. Most ERs have a lot of split shifts because we have this kind of if you picture the patient population increase pendulum throughout the day, like lower 6, 7, 8 a.m. kind of increases throughout the day, comes down on the other side around midnight or 1. So we have a lot of these mid shifts, but our primary start times are 7, 6:30 or 6:45, 7 o'clock, and then 6:30, 6:45, 7 o'clock at night. And you kind of do this like shift huddle to talk about things that are broken, things that are missing, how we're staffed today, who our sickest patient is, who may need help, how the psych corner is doing, how our psych pod is doing, how different people in the unit might be best able to help unit. Oh, we're a little slow right now, so if somebody can stock the med room or whatever it is and kind of talk through it. And then it's only like 4 minutes break, go team. And then you go and get what we call a report on your patients. So you've got your set of patients, however your facility designs that. Usually 3 or 4 patients is pretty typical, unless it's an ICU level patient, in which case you'll have fewer of them. And you'll talk to the shift nurse before you, and they'll tell you about what they've done and what's up next.
And they kinda brief you like, "Hey, you've got 4 rooms here, and, over here we've got." We'll get into the I'm
Yeah,
obsessed with
Mr.
the lady with
Smith's
the
here
3
for
butt
belly
cheeks. We'll
pain,
get to her
Jonathan's
later.
here for his LSD overdose. I've got, whatever else is going on.
So, and you're working like 12-hour days, right? I mean, you do like 4 shifts of 3 shifts of 12-hour days.
It's 12 and a half hours because they deduct for lunch at every facility. So you go from, 12 and a half hours minus that point 0.5 for your lunch break. And full time is 3 shifts per week, and part time is 2 shifts per week.
Well, why the long I mean, you would think you would want some fresh people in there just because it's so intense all the time. You just go, go, go. Maybe is it for continuity? They just think, well, we've got them here. They're in the groove. Let's just keep them as long as possible. Because you would think that, you would want to fatigue and just like overload would like you'd want to keep these people shorter shifts. Why, how do they arrive at 12 hours? It's just intense.
Honestly, this is something that's kind of come up over the last several years. It's come up in discussions with administration as well as staff. Most of the 12-hour shifts were changed actually for staff satisfaction, improving the total number of days that you're having to come in. A lot of people make a long commute to work, or it allows them to then they can take days for doctor's appointments. They don't have to use as much sick time to cover their own life, I guess, because you're only working then 2 to 3 days per week, although that puts you at 36 hours and you're working weekends. So I think the idea was to cover more hours with a fewer number of people. And then when they tried it, the nursing staff really liked it because we like coming in, kind of hit it hard, bang out your shift, and then you have more time for you. I will say that when I'm my first day off after like 3 in a row, I am like a zombie because your brain has already used every neurotransmitter over the last 3 days just to not die and to not let somebody else die, and then you're like on the couch incapable of movement for for a full day afterwards, and then you regroup.
You're basically in a state of hypervigilance for 12 hours at a time. You're never just like walk to the end of the corridor and take a breath because somebody's going to grab you and need something. It occurs to me that huddle is a perfect word for it because you have such a short time to communicate that much. And I'm like 4 minutes for the huddle, and like you guys are just off, and everybody's sort of self-directed all day. I mean, doesn't that get gummed up if you've got a nurse that's new to the hospital, or is there a certain type of nurse that needs more instruction? I just know with every other job, like when I was a landscaper and I'd been there the longest, there's always like some newbie is like, well, what do I do now? I was fucking find something to do, you know? I mean, like, look around you. This place is a mess. I
Use your
mean,
eyes.
yeah. So, but I mean, I understand it's like hard for some people to like, especially in a situation where the stakes are so high. So your charge nurse, this is the one, and this is a rotating thing, as I understand. She's the one that leads the huddle, but sometimes you're the charge, right? Like everybody on your nursing team, what is that, 6, 7 nurses at a time, or
So, this is something that happens. You train to charge. It's a role that you're assigned for the day, but it's not something that's like arbitrarily assigned. Usually, you're a nurse. On night shift, you should be a nurse for at least a year before you get trained to charge, but that doesn't always happen because it's like, well, you're the most senior. But on day shift, more senior people are on days. And even mids, I work typically a mid shift. That's my preference, starting sometime between 9 a.m. and 1 p.m. I don't like the early shifts and I don't like the night shifts. But yeah, your charge nurse runs it. They've usually been there 4, 5, 6, 10 years. And of course, there are people who are heavier needs nurses. And I always just assume that as long as they're asking me questions, that means that they're pretty safe. The problem is when somebody doesn't ask questions and you know that they should be asking questions. That's your scary nurse. And I
so
think
like
every
she's just
single
like
nurse
looking
will
at a
tell you
vial.
that.
What's this? Maybe this will work. I mean,
Yeah. Yeah. Anybody was like, "How does this connect with that?" Or "What does this?" And you're just like, "Oh my God, thank you for asking. I really appreciate that you did that. And let me show you so that it's done correctly the first time. It'll save you time. It'll save me time later from fixing the problem, and it'll be safer for the patient." So,
so the
yeah.
charge nurse is basically like the court general. So she's not, or I see. Look at that assumptions I make. There are
Yeah.
male nurses.
There's a lot. The
Ben
ER has
Stiller
a
comes
lot
to
of male
mind.
nurses.
Yeah.
The ER tends to be closer to this is just an estimate, maybe 30% to 40% of our nursing staff in the ER is male,
And
depending
what's the
on the
difference between a
facility.
tech and a nurse?
A tech is, it's like kind of akin to an assistant manager and a manager. So let's say that you have an assistant manager, that is your tech. They have a training course, they have a certification through the state. They are the ones, they do slightly more like ancillary tasks. So walking a patient, getting a urine sample, doing EKGs, drawing labs. And then you've got like your manager level would then be your nurse. And that would be things like assessments, reassessments, pain medications, or any other type of medications, really. IV placements, depending on your facilities, some techs can do them and some techs cannot. And then after that, you would have like your director would be like a nurse practitioner. So they have prescriptive ability. They do larger assessments. They can run their own practice. So there's like varying levels of nursing on this nursing track.
And now the doctors, they just kinda come in for the victory lap, it seems like. I mean, everybody's there to see a doctor, like, "Get me to a doctor," but then, first you gotta this person's gonna lead you to triage, and then this person's gonna ask you, your date of birth or, like, and then but then you get the doctor for, like, 3 minutes, and you guys are he's being brief. He "See how I'm doing this? What a jerk. I got female." I mean, I don't even mean to, it's just like, conditioning. But, like, the doc comes in and she's been briefed by a bunch of people. And, I mean, you've basically already sort of almost kinda halfway made some sort of diagnosis in a way, or
Depending on your provider and depending on your nurse is the one driving the show or your doc's the one driving the show. We really do a pretty good job of working as team members. Neither of us are above the other person. And I know that the hierarchical system will tell you that the physician is over the nurse and we're fulfilling their orders, which is true that we can't perform tasks without orders, but we do run on protocols also. So it's kind of a multifaceted approach. And the thing that I really like about the ERs that I've worked in is that I know I've mentioned this at some point before. It's like this trauma bond where you guys work really hard through really challenging things together. And so you learn to trust the people that you're working with. I have one provider, and I'll tell you, this is a very short story. So this guy, he is always cranky. He's one of the crankiest providers I ever worked with. And it's like a long-standing joke, and he's aware of it. This is not a secret. And he was really mad that they put a shortness of breath patient, which is somebody who comes in with some sort of respiratory something, into one of my rooms when we had a trauma room available. And he was like, "Why the fuck are we putting them over here? I don't understand what's going on." And they said, "Oh, we put him there because Lexi's over here with you." And he's like, "Oh, well, I guess it's fine then." And he just stomps away. And so I think that the thing that we don't recognize a lot is that um you know, we learn who we can trust and how we can trust them. And after X number of years of working together, apparently there was trust there that there wasn't with this other nurse.
Yeah, I think that's so interesting you use that word trauma bond. Not to I mean, this equivocation doesn't work perfectly, but when I used to work as a PA, the thing about, like, commercial production and stuff like that in film is that they treat it like it's life and death. I mean, like, right, they
Oh,
send you a
yeah.
script on Christmas. I mean, just everything. It may as well be life and death. The stakes because
It's
it's
no
money,
joke there,
money,
man.
right? Yeah, yeah.
Yeah.
And so like you would work as a PA and you're just the shit heel. I mean, like everything rolls downhill. You get blamed for the weather, like right, and you're working
Oh,
like
absolutely.
12-hour shifts. And like
Or
a lot of
longer.
it's just sitting around. I mean, I used to like find a fucking cube truck and go take a nap sometimes. You know what I mean? But like you get treated so badly by because it's so hierarchical and like the AD's job is not, and I've been briefed. I made it all the way up to like first AD for one job, and the director and producer tell me you got to be meaner. You're too nice to your staff. You got to treat them. You got to crack the whip hard, which is just and that's just not how I operate. But anyway, that's how you felt there was sort of trauma bonded when you go through these experiences where it's sort of the proletariat experience where you're getting shit on by the upper end of the hierarchy, and it really bonds you together, and you know that you really have the power. So I like this idea of trauma bond. It must be much more intense when you're dealing with, uh, with life and death. What do they get wrong, and what do they get right on television?
I think to your
And you
PA's
can tell me shows that do
conversation,
it well. I mean, you can talk
yeah,
about The Pit,
I
we could
think
talk
the
about
biggest
House. Yeah.
Yeah, the biggest issue is that well, okay, so my favorite thing about Grey's Anatomy is that the physicians meet the patients out in the EMS bay. No way. Pa Physicians are walking their own patients? No, no. Um, and the other thing I would say is, like, I would implore these, the set production and the PAs to well, the PAs can't hire them, to hire someone who works in medicine to just make it so the equipment looks like it's supposed to. You know, I worked on sets before too. I was very heavily involved in when I lived in Hawaii several years ago. North Shore, Lost, those were, like, my big ones. But then I still have done a lot of, like, print work, with my kiddos up here, and then I worked on, a medical filming last month, and you could tell every single person worked there was in medicine because they would be, like, taping lines and doing all this like, everything that they did looked real, and so that's the biggest thing that they don't do is they don't employ somebody who can just say, like, "That tube doesn't go in someone's mouth." And because then every single person that works in medicine thinks that tube doesn't go in someone's mouth. Like, I can't even hear what's going on in the rest of the scene because all I'm thinking about is, like, that's supposed to be someplace else.
See,
And it's
exactly.
very distracting.
Why can TV and film get away from that? Hitting false notes. Like as a novelist, I know I cannot hit any false notes or I'm going to lose the reader. I one time had it was thank God it was a galley, so it hadn't been it went out to like 500 people before it was actually published. And I had a horse that was cantering instead of trotting or trotting instead of cantering. And I heard from like 150 horse ladies. They were like, That horse is not trotting. That horse is cantering." And I was like, whoa, if I can't get that right, I better not write like maybe the bisexual experience wrong or, write that 89-year-old woman wrong. You can't hit those false notes. And yet, films and television do it constantly. Every time I was watching something the other day, some comedy, and they were closer than most, but it was about publishing. And it was like the agents coming to the writer's house and it is so many things that were like, I'm like, this doesn't work this way. Like, or I remember watching Californication and like David Duchovny's doing a book tour 12 years after his book is published. I'm like, it's not the way it works. It kind of happens like within a few weeks. But
Like,
like
immediately.
it makes me
Yeah.
think like, well, if they can't get this right, I mean, like, how are they doing the legal system or the healthcare system? And so what you're telling me is they usually get it wrong.
They do. I have, so the things that I really have enjoyed recently is I've really enjoyed Saint Denis. I don't know if am I supposed to name names? Like, that's one of my favorite
Yeah,
things
no,
right
no, we
now.
wanna talk about popular
Okay.
culture
Okay. So I
because we're
really
so
like Saint
unpopular. It
Denis.
kinda
It
yeah.
was like Scrub I loved Scrubs too because it doesn't play up the, like, hype of medicine. It, like, really demonstrated the bonding and the mildly dark humor and the funniness that comes with people when you work with a whole bunch of really high caliber people, you get high caliber jokes and dark jokes and very death jokes, but that's what we have to do to survive this. But I really love Saint Denis right now. I am enjoying watching that. And the other one that I've heard really good things about, but honestly, I'm in master's program and I haven't had a time to watch it is The Pit.
Yeah,
I've
Jason,
heard
our my
really,
producer wanted me
really,
to ask
really
you
good
specifically,
things
yeah.
about The Pit. The only thing that I have heard about The Pit is I do not think that they discussed their shoulder dystocia scene with a labor and delivery nurse because I am also a labor and delivery nurse and I have watched just that tidbit and that is not how that works. But the rest of it is so accurate. So I don't know. It sounds like the main character, his mom was a nurse for a long time. I don't know who they're consulting on set. I don't know how they organized it, who's running it, but I have heard that they've done a great job. So I'm
And
excited to
why
watch
don't
it
they
when I'm
always
on
do
break.
that? Like, when they made the fundamentals of caring out of my book, The Revised Fundamentals of Caregiving, they usually don't want the writer on set, like the novelist, because they're gonna be
Yeah.
precious, and they're, "Well, why'd you make Ben 37? He's 35 in the book, and, he has blonde hair in the book, and why," they wanna keep you away, but I was on set, but which was really smart because what they had me there is consulting on the caregiving element. Like, how do I pick up Craig out of the wheelchair? How do we manage toothbrushing? How do I set him up the meal? These little things. It's so easy to have a consultant there. And Hollywood never does it. I remember once working a
I know.
PA on a science fiction film. It was basically just Alien with a dog instead of a cat, or a cat instead of a dog. I forget which one Alien had. They basically just switched that, and it was really bad. And Sam Bottoms was in this movie. And I remember once they're getting ready for liftoff, and they're in deep space somewhere, and the guy's checking off like thrusters, and then he goes, what was it? Compass. And I'm like, kind of elbow in it. That's in space, dude. There's no polar north.
No,
Compass? How did
there is
like
no
how did
north.
yeah, right. How did that get by? Like don't they have so like I'm addicted to House, right? Because the guy is just even my 15-year-old
He's
will
so
watch House with
crass.
me.
He's so funny.
I know. Like he walks in and some kid's got a big tumor on his face and he's like, ew. But even my 15-year-old says, oh my God, he's so hilarious. But like I gotta feel like that show is it's gotta be one of the more unrealistic shows.
I mean, I would say yes and no, right? There's always anomaly patients. There's always you hear about people who've seen 17 doctors and can't have their stuff diagnosed, and no hospital would maintain employment of a doctor who's this
Gambling on patients' survival
risk
rate.
management's worst nightmare, right? And but at the same time, he's incredibly smart, and the writers did a really good job of creating these atypical scenarios. They throw in that he has a clinic days he has to do. There's the relationship with Cuddy. There's the relationship with his staff. It's a great show. I rewatched pieces of it, and every episode is so different. And there's pieces of it where you're like, oh, beta thalassemia. I know what's coming next. But then
That's
but that's the
impressive.
part that makes it
You must
fun
be a
is that
real
as a
fun to
medical
watch House with.
professional, I can play along a little bit. Like,
But is
I
that
don't
stuff
work
pretty accurate? Because they come up with some crazy stuff. I mean,
they come up with some crazy
they have
stuff.
somebody helping them through, like, this drug
They
will do this and have this side
They
effects.
do. They have to have a couple of people on set. They've gotta have a pharmacist. They've gotta have a set designer who has worked in medicine or consult with somebody who does, because their stuff is pretty good. You don't walk in and have the EKG leads on the wrong spots. Like, this should be really simple Google that the colors go in a certain place, but that's something you see a lot. Or yeah. I do enjoy House very much. It was a great show.
So Jason and I have done a lot of talking about, because we both had well, I'll just talk about my own experience. I don't need to throw Jason under the bus here, but, like, I had this anxiety thing where it was like I was having physical manifestations and nobody could figure out what was wrong with me. It was a kind of this ghost in a machine scenario, but it was kind of frustrating because it seemed the way healthcare is set up is that like a tree with these different branches, and everybody wanted to just check off one thing. It wasn't this, so we're just gonna send you to this specialist or this. I always wanted House. You know what I mean? I think we
Yeah.
all want the doctor that's just gonna approach this holistically and check each off box. But what happens is you get sent from specialist to specialist to specialist, and you feel like there is a communication breakdown and that they're just kind of
Yeah.
moving you along these various conveyor belts. Is that a Western medicine phenomenon or
Yeah, it is and it isn't. So each person has their specialty. So if you go in with X symptoms and you see a neurologist, they're going to come up with a neurological cause to rule out. And if you see a kidney doctor, they're going to find a kidney problem to rule out. And if you see a cardiologist, they're going to rule out cardiology or some sort of heart related disease. I think one thing that's really helpful is having like an internal medicine specialist, which I think is what House probably is. I haven't actually looked up any of his credentials, but they're more like this holistic everything doctor. And then they consult with more specific subsets of physicians, because there's no way to know everything. Medicine is so big. And once you know just enough, you know that you don't know anything. And you're going to learn every day for the rest of your career. So, yeah, it's super frustrating as a patient to try to navigate this, especially with American healthcare system. I'm not going to get too political, but like it doesn't make sense that I have to go to one person to get a referral to see another person to pay a copay to see a third person
Right, because
to
that's
get
a day off.
imaging
I
that
gotta
I
take
can't
time off work
afford.
just to get a referral. This person's not gonna look at me. They're
Yeah,
not even gonna they're not even gonna take my blood pressure. They're just I have to show up, and
I
that's
have
like
to
I gotta
show
get a
up.
babysitter and like yeah.
Yeah. I'm gonna drag my kids in with me to the rheumatologist so that I can get a referral to go see this other, but like and then it takes 13 weeks to see your primary physician and you're like, "Why are the ERs so busy?" Well, it's every person who can't see their primary care doctor. And we don't prioritize primary care. We we prioritize tertiary care. Like after you have symptoms, after you have disease process, that's when you seek help in American culture. I don't know what it's like in other cultures. I've only lived here, but it doesn't seem to make sense. I've read stories all the time of somebody on vacation in Finland who finds a lump in her breast and she goes to the clinic and they do a screening within the next 12 hours and she knows it's benign. Like it's just other places, I know that their populations are significantly less. I know that they don't do nearly as much in research, so their healthcare in some ways is a little cheaper because they're not funding a lot of as much research, but it just seems disingenuous to our population to say, "Oh my gosh, why are you so sick all the time?" and then not take care of anyone until they're sick.
Yeah, well, the
So,
extraterrestrials, they just put this thing, it's about this big, and it's just a probe, and they just
yeah,
put it up your
just
anus,
under my
and they
skin.
figure out everything. I mean, we do that with temperature, but they can tell you everything that's
Oh,
going
yeah,
on
you
just
spit
like
in a
that.
cup and they
Yeah.
already know everything about you,
And then
your whole life.
they drop you and you wake up later behind a dumpster behind Walmart, and with no memory of it, until you have night terrors. Um, Not personal experience here.
Sounds
One of my
personal.
pet peeves, I wanted to ask you about your pet peeves, but one of my pet peeves is somebody is like, I don't know, is this a product of the modern era? Is this the product of just worker overload, too much on everybody's plate? But it seems like, I mean, and you could say this in general about American culture, but we've lost a certain. I can't count how many medical professionals I've seen that just have awful uh, social
Bedside
skills,
manner?
bedside manner. I mean, I've noticed this with librarians, but that's why they're librarians. I know a lot of librarians because 'cause I'm a writer. There's some weird librarians. They're just not they're almost kind of on the spectrum. They're not like you don't have very lively conversations with them. Sometimes they're just kinda odd, but, like, you would think with a medical profession, that would be part of it, is just the first thing you wanna do is keep the patient calm. I was having a panic attack one night, and my, like, nurse tech guy was so unhappy, "Ah, you're fine. Nah, can't be the medicine. It can be" I was just like, "Just help me out here, dude," a little hand-holding maybe. So what do we have to thank for that?
Um, Everything. Uh, Burnout is a big thing. Not getting, vacation days, not, especially our medical providers, they work a lot, especially in med school, especially if you go to, like, a teaching hospital, those are, like, 90-hour weeks. I wouldn't be nice either. A lot of people get frustrated with dealing that's maybe not the right word, dealing with the same thing every day, right? So, like, if you have this system of primary care, again, goes back to primary care that doesn't work over and over and over and over again, and you're taking care of these problems that shouldn't be your problems. You went to school to be an emergency medicine physician, and you're dealing with low-level blood pressure issues because they can't see their doctor, or you're refilling prescriptions for psych meds because they can't see their psychiatrist, or you're taking care of these things that should be able to be taken care of by someone else. You feel like you're just kind of absorbing the American healthcare system. The other thing that happens is our shifts are long, and as a nurse or a nurse tech or a tech, you often don't get breaks. And so if you're doing 12.5-hour shifts, that's cool as long as you're able to like feed and water yourself, bio breaks. I mean, there's jokes about nursing bladders because we pee once per shift. It's just it's always go, it's always on, and you can only work at Mach 10 for so long. So then when somebody comes in with something that I would not put anxiety in this list, but something that's not acute. My toe's been hurting since 1960. I've had belly pain for 9 months. I've had those things you're like, "Okay, why are you here in the ER today? Like what changed today to bring you in?" And it's not that I'm unhappy taking care of you, it's that I'm trying to figure out what in the world changed that you wanted to pay a $350 copay today to come and see me? And what's expected of me? when I have limited resources here too. So I hope that no one's intentionally being mean, because that's not helpful for either party. But it can be a very frustrating job to see things that maybe don't belong in an emergency department.
Yeah, and I mean, you're like we said right from the but you're in this constant state of like hypervigilance where your adrenals are going. And you bring up an interesting thing, which is that patients can be real assholes too, because they're stressed out and they're in a state they want some answers, and they're looking at you as some sort of service oriented, like they're ordering a coffee from you, and it's like, give me my answers I want. What percentage of these people are just total assholes?
I at work would agree with everything you said. And since I'm off work right now, I kind of feel like most people come in when they feel their worst. I don't have a single person that doesn't visit me that this isn't one of the worst days of their life that they end up in the emergency department. That being said, true assholes, I would say probably 5%. People responding in pain and anger and frustration, probably 25%. And I think that's where your like PR stuff comes in, like, oh, gotta be nice, gotta touch, hand holdy and stuff. And you really need a good charge nurse or assistant nurse manager or risk management person or patient relations person. Sorry, that's your PR. It's a patient relations person who can kind of come in and smooth it out and say, I know you feel like shit. I know you've been blown off by 7 providers. I know this isn't your first stop today. And we can't fix it, but I hear what you're saying. And you kind of need somebody to schmooze it. That being said, probably 5 to 10% of people are true assholes. They're the ones
That's
who are
not.
yelling at
I
you,
would have guessed the
cussing at
percentage was
you.
higher.
Yeah, well, if you add that to your 25% of angry people, I'd say roughly half of my patients are incredibly pleasant. They're there because they're looking for help, and I represent help. And as long as I go in nice enough and kind enough, the majority of our patients are very, very kind. Um, they're you and me and my kids and my mom and my dad. They're us, right? And so
I
I don't know.
overshare. They never want I end up telling I just do this in general on this podcast, everywhere, any conversation on an airplane, in a line, I overshare, and the nurse is just like, "Okay, I'm just trying to get your vitals here," and I'm giving them my
That's me
symptoms for,
too.
like, the past 13 years. I'm trying to be as helpful as possible, but I'm probably
Yep.
overloading them. Um, yeah,
Now we can sift through it. That's our job.
I wouldn't make it very long. I mean, even 50% of people being a jerk to me, I have thin skin that way. Like, I'm like, "What did I do to you?" Talk to my wife about this. Like, "Hey, why were you talking to me like that? I didn't do anything. I didn't do anything." And then also the peeing once for 12 hours, that's insane. I pee like 3 times an hour. TMI. I know, but, like, I honestly couldn't
Most
do it.
people do.
They would let me go. I mean, would I be able to get away with that? I'd be like, "Oh, I'm going down to get a syringe here," and then just poke into the bathroom.
I'd be like,
I mean,
"Where is John?"
or would yeah, would that but I'm quick. I'm quick. I
Yeah.
just do it a lot.
Well, there
So,
he
I
is. Oh,
wonder
we're good.
now you've told me you've got some great triage stories. I hope that this is one you might wanna have a barf bag available, people, but, tell me again about the lady that came in the Gucci sweats.
Oh gosh. This is one of my favorite stories because it so accurately depicts that you never know what's gonna happen. So I had a zone this day or a pod, and I was assigned a set of rooms. And one of my rooms emptied out, our lobby was full, and they put this like lower acuity patient in my room. So I know we've talked briefly, acuity is like 1 is super, super sick, dying, and 5 is like low level, needs a prescription refill. And most of our patients are somewhere in between.
So pro
So they
tip, just say you got shortness of breath. That's what I've learned.
Yeah.
If I go in
Yeah,
there with a
and,
sprained ankle, I'm like, "Oh, I'm really having trouble breathing. I
oh,
got a little tightness in my chest
you're
here. Could
gonna
you
have
look at
to
my
fake
ankle?"
your vital signs.
Yeah.
You'll have to fake your vital signs too. So if you can hold your breath for a really long time, it might work. Um, but so yeah, so I've got this lady who is level 3 or 4. It's like a lower level acuity, and I was like, sweet, hopefully like a simple patient because all my other rooms are full. And she comes in and she's wearing this velour tracksuit. It was like, like a juicy couture velour pantsuit set. And she walks down the hallway to the room, And as she walks past me, I looked up and she's got like a third butt cheek. She's got like her normal tush, and then she's got like this additional butt cheek on one of the sides. I think it was, I can't remember which side, one of the sides, like this thing. And I was like, wow, she's got 3 butt cheeks today. Like,
Is that a thing, or is that what you're thinking?
I
Like,
was
is
like,
this a thing? And
what is happening? I've
one
not
big
seen this
butt's not
before.
enough. You gotta have a third butt cheek now.
Could be anything. I was like, that was odd. And, I try not to judge because, like, everybody is made differently. And you learn that when you go into a field where you see naked people's bodies every day. So for like 16 years, I've just looked at different people naked. And it's kind of an odd piece of my job. But, like, you just recognize that, I don't know, is that normal? Does she have a huge lipoma? Like, I don't know. Anyway, so then I look on the board and it says that she's here for an abscess, which is an infection under the skin. I was like, okay. And I go in and the butt cheek is the abscess. So she's got her 2 butt cheeks, and then kind of on the side, she's got this like additional growth, and it's pretty red, really swollen, and it looks incredibly painful. And it's no wonder she's wearing those juicy pants, because I bet her jeans could not fit over that bum. So we go in, the provider that I'm working with that day, we set up all of our stuff we call it I&D, incision and drainage, to this site. So we've got a scalpel, we've got lidocaine, and we've got needles. And it's not my first day, so we've got suction set up because there's no fucking way that I'm trying to clean this up without suction. I've got the Yankauer connected to the wall. I'm going to just suck all this stuff out, potentially. So this doc and I are in there, and this was pre-COVID, so we didn't have to wear masks all the time, but we definitely did. It's a very good idea to do that whenever you're doing an I&D. So he goes to
And
inject
even
the
goggles. Didn't you have goggles on too?
He had to go. It's a face shield. It's a mask with like a face shield. It goes all the way around, like side to side, attached to the mask. He was covered. And I was not as close as he was. I definitely had a mask on, and I was backed up with the Yankauer ready for whatever was happening. So this
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 is like a
poor dude.
medical shop vac.
Oh my, it is. It's like a long plastic tube that's perforated at the end that then you connect to wall suction, and you give whatever the negative pressure is that you want as your suction level. And so he goes to inject the lidocaine in this wound, and when he puts the needle in, he injects lidocaine, and as he takes it out, there's just this stream of pus coming out of the wound. Like, there's so much pressure in there, it doesn't even wait for us to lance this wound. It just starts to stream out. Like
It's like a
envision,
geyser of pus.
yeah, like when you've got a baby laying down and they start to pee, that's what's happening. There's just urine out here. So, it's just pus. And so then we do a second time, and more pus is like starting to kind of drain out. Obviously, this is the thinner stuff because otherwise it doesn't fit through this size hole. So then the doctor uses the scalpel to lance the wound, and it just kind of pours out like magma, like chunky magma. So you've got like this kind of watery cottage cheese
Nice.
stuff flowing out, and thank God for suction. Can suck it up, clear it up. In part because it smells so horrific. It literally smells like feces. So the bacteria that are produced and proliferating in a wound are often the same ones that are in your gut that cause your stool to stink so badly. That's the same kind of bacteria, or similar byproducts are created
Eesh.
in
And
these.
you
And
guys
it just
sometimes
smells
put
like
like
poop.
some peppermint oil under the hood just to avoid that kind of stuff, like they do when they're doing
Yeah.
when they're
I
doing
love to use
post-mortem
peppermint or
stuff.
mango, some kind of essential oil on the inside of my mask. Sometimes you put it on one mask, you put a second mask on top of it. Depends on what you're going into. You do that a lot with rectal bleeds too. That just smells so bad. So,
Well, we're getting
um,
right into my area here. Jason's
ooh,
probably just cringing. Many listeners are
yeah,
walking away from the podcast right now, but I love it. Uh, there was a Michelin lady too, right?
yeah, there was
Didn't you have a
that was
lady that
my
the human
yeah,
parade
story
float?
that I will never, ever, ever forget is that I was pretty new, and this lady had had a fall at her house. It was night shift. It was like 3 in the morning, and I had a different set of patients, but my charge nurse brought me in to help in this other room, and she is, like, tiny. She's, like, I don't know, 5 feet tall, 105. She's laying flat on the bed. She had fallen at home and hit a table or another object, and they put a breathing tube in her throat to breathe for her and brought her into the emergency department. She lived close by. Um, so I bring her in, put her on the table. We're doing all the stuff we normally do with people that are intubated. So making sure that the breathing tube is correctly placed, putting in a catheter for her bladder, putting IVs in, making sure everything's kind of organized. She goes to CT and she comes back. And when she came back from CT, she no longer had, like laying flat on the bed, she no longer had breasts. She was essentially inflated. Her belly was the same height as her breasts, and her arms were so swollen, and it went all the way down to her hips. Everything was like, it was the same person. I don't even know how to describe it. It was like she was inflated, like a balloon. Like her belly was now the same height as her breast. Everything was full. And when I touched her arm to put it back on the bed, I could feel Rice Krispie treats under my fingers. So every time I would move her, it would just crackle under my fingers. And I had never seen anything like it. I've never seen anything like it
Get
again.
house in there right now.
It
This is
was
exactly like a house
wild.
case.
It was wild. So we put her hand back up, and it's called crepitus when you have that kind of it's air under the skin is what causes this Rice Krispie treat sensation, and it's moving in between the muscular tissue. And so anyway, she had both of her lungs had collapsed during her fall or during intubate. I don't know when it happened, but that's what the issue was. So when we were breathing for her, we were just pushing air into her body.
Well, how did she live through that? Like if her so you're pushing the air into the lungs and they're not inflating. Does that mean we
Yeah.
can live without lungs if we just breathe through
No.
under our skin?
So, I mean, without getting too technical, there's like different lobes of your lungs. You have 5 lung lobes in a normal person, and what happens is you lose the negative pressure in there that holds them all open. So she was probably ventilating on these upper areas. It's not usually the entire lung that collapses, but a portion of it. But because it had opened when we were filling her with air, it was seeping into the rest of her body. That being said, we put in chest tubes on either side. So they cut a little cut in between your rib cages and put a tube in there and set that to suction. And it actually sucks the air kind of back out and creates a negative space so the lungs reopen. The rest of the air will be reabsorbed slowly by her body. Granted, I don't actually know. One of the sad parts about the ER is I actually don't know if she survived because I never hear what happens later. You don't go back into patients' charts and reopen them or re-review them
How do you resist?
because I like my license.
Oh,
It can
okay, so
be
you're not allowed to.
yeah,
You're forbidden. Oh,
it can
that's
be a HIPAA
another reason I couldn't
violation.
I have to know. I have to have
No,
resolution. Every
I
person's a
know.
story. Oh my god.
It's really hard. Sometimes I do ask the providers, and when there's some thought process that if it's for learning, it's okay to share the outcome of a patient because you want to know what you did well or what you needed to do better or how you could improve, not just you, but as a practice. If we never reviewed people's charts, we would never improve patient care, right? So there's some level of doing it from curiosity versus doing it from learning. And so I think that's kind of a weird a balance to hit, but I often check in with the providers that later took care of the patients and say, "Hey, how did that lady do? Was there anything we could do different?" And kind of figure out to some degree what happened. Like, "Oh yeah, she passed away, but they found this on her autopsy or whatever." I've had a couple of patients that we ended up autopsying because we were so confused about what was going on with the patient, that we just had to figure it out so we can make sure we don't have the same thing happen to somebody else.
So if somebody is in such bad shape, like a bullet wound or something, you're not triaging them all. They're just gonna go straight into, like, an OR or something like that, right? Because what I was
Well,
getting
they need to be stabilized. So, typically, the emergency departments that I've worked at are not ones that take gunshot wounds by EMS. That being said, I've been brought weird things by a car. People drop their friends off outside. I had EMS tell me that they had a patient with a facial laceration, which is a cut on your face. And when he arrived on EMS, there was a knife in his eye socket. So they don't always follow the protocols that they're supposed to, but gunshot wounds should not come to any of the ERs I've ever worked at. But they do need to be stabilized. You're not going to roll into the OR with all your clothes on. So you're going to go to some sort of a trauma bay. You'll probably have multiple people putting IVs in. They'll make sure that they have a breathing tube in place. They'll make sure that they have a catheter in their bladder. All of this is done simultaneously with multiple people. This is that trauma bond, right? Like you've got lines, you've got meds, you've got respiratory, and you've got other tubes. And they're like, okay. Um, so once they're prepped and stable, they'll move to the OR. But very infrequently do we go to the OR or anywhere really without some sort of preparatory work.
I mean, have you ever lost anybody in triage? I mean, somebody that came in such bad shape, or can you even talk about
Oh
that
yeah.
without it? Yeah.
I mean, I've
Like,
I've
died in the
probably well,
examination room on your, like, what
oh yeah. Oh yeah.
Hey.
We have I mean, mm, I've I don't do bedside as much. I do charge more now, but I would say that we probably have a code every other day in our unit, sometimes every day, sometimes multiple a day. I've had some days where I've got, 3 or 4 going at any given time. It just depends on the day. During COVID, we probably zipped 3 body bags a day just in my unit, let alone the others. So mine are less from trauma because they would go to a higher level of care than what the facilities that I work at. Mine are usually, I don't know, could be seizures or old age, drug overdose. We get a lot of other related respiratory stuff. Asthma still kills a lot of people, especially in our Black and brown populations. Really high health disparities there still. So,
Well, we've
yeah.
all heard the Richard Gere stories, but what would you characterize as one of the more embarrassing, things you've treated? Where, because I feel for
Well,
the patient that, like, I did something really stupid here, now I have to explain how I got this, whatever, this
yeah,
hamster up my butt or whatever, right?
there's a lot of things there's a lot of things that people put in places that those things are not designed to go. Um, and I think what's more embarrassing for a lot of those folks is a lot of times they have to go to the OR to have them removed. So it's usually, we call it a foreign body, which just means something that's not usually there. And there's like not scary or there's scary foreign bodies that are not weird, like a kid who inhales swallows a coin or something. But usually it's men putting things either in their urethra or in their bum, and I
Urethra,
am
I don't even
unsure.
get that one. I mean, I guess the bum makes a little sense to me, but, like, I
I
mean
know. I
anybody
don't
who's ever been
know.
tested for an STD knows you don't want anything up in
Well,
your y
put well, and you put, like it's like paper clips or Q-tips or
ah!
stuff, like, inside, and then you have to, like, OR removed. I just don't understand. It's something that most guys are so mad when I'm, like, placing a catheter. I can't imagine them being like, "You know what I'm gonna do today?"
Yeah.
But to each their own.
That must
Usually,
be
I've
some
had
sort
somebody.
of, masochistic,
It's gotta be. I think
inclination
it
because
has to.
I can't that's not something that feels good. I mean, like, I get a little yeah, and in the bath, I get a little soap up in there, and it's just horrible. I can't imagine a paperclip, no.
Yeah, I don't get it. There's gotta be some level of psychiatric component to it, but, yeah, I've had one guy came into triage one time, and he's, like, literally stood in front of me, which sometimes I'm like, "Oh my god, this I'm gonna get hit in the face." And he goes, "Is this where people come when they do stupid things?" And I was like, yeah, pretty commonly. He's like, "Yeah, I did pretty stupid thing." And I was like, "Oh, that's why you're here?" And he's like, "Yep." And I was like, "Tell me more about that." I'm like, he had an entire votive candle up his bum. He tried putting it in the wick side down so you could pull it back out, but it didn't work.
So
So
what do you just put him in a hot room? This'll work itself out in
it
about
was like
5
this
hours, or
long. It was
y
like the whole like 12-inch votive candle.
with the heat would just melt it out eventually, right?
I don't know. I don't know if our body I mean, put yourself in a hot bath and see if it works. I can't. I don't think. I don't
Yeah,
know.
just
I don't
light
know.
the wick.
I
I
think
mean,
yeah. We've pulled mugs out of people's bottoms, pool pool tubes, like things with handles on them. Like I don't know, man. It's a
crazy,
wild
man.
ride.
People are very interesting. I would, note to self, I wanna get a guy that tried to put a mug up there. I'd just like to kinda interview him and see what he
Yeah,
was thinking there.
pool balls, like just anything you can think of, conditioner bottles, and then everybody, please don't tell me you fell on it. Like we know you didn't. Okay, and that's
Mhm.
fine. I mean, maybe
I
you're saying it for
fell on a
yourself.
can. I was doing
I
my best
fell on
Jack
the
Flash
shampoo
impersonation,
bottle.
and
The
whoops.
entire shampoo bottle, I fell on it and I had somebody who had put um we ended up having to do an x-ray to verify number. He told me there was a bowl of them, which I don't know where this guy's hanging out, of somewhere between 12 and 15 mini vibrators. And I was like, "Okay,
Not
okay,
your grandma's house. I mean, I've
where
seen,
are
like, a
you
little
hanging
bowl of, like,
out?"
hard candies, but who has a little bowl?
How did you lose count? Like, you just grabbed them and kept going? Or, like, would you try like, okay, man.
God, it is just crazy the levels of humanity. I mean, like, the your job is absolutely crazy. This has been super enlightening. So I'm starting to wind down on time here. I should have got you started on this stuff because I could have a whole nother episode just talking about the bizarre shit people put in their bodies. But, one thing I've been wondering about, this is another thing, like, when you've got some sort of ailment, ghost in the machine ailment like I had, and you're trying to figure out what it is you go down that rabbit hole of Google Medicine, or, tell me about, I mean, I would think that I'm usually pretty good about it. Sometimes I'll be going, "Well, I don't think it's this because of this," and then, I might get the nurse practitioner might, like, hoist an eyebrow like, "Oh, you know about that? That's impressive," but usually I kinda feel like it would be sort of annoying, like, just leave it to the professionals. Like, what kind of problems does that cause for you?
Well, it causes a lot of weird, conversations. Um, so I'll do 2 short stories on this. So my ex-husband told me one time, "Babe, I think I have AIDS." And I was like, "Sir, where did you get the AIDS from, first of all? And then second of all, what makes you think that?" And he's like, "Oh, my throat is sore." So that's the kind of problem that it causes is you get somebody who doesn't check their sources, immediately jumps to the worst possible conclusion. And then I was like, "Okay, well, let me take a look at your throat." And I was like, "Oh, you have postnasal drip and it's causing irritation to the back of your throat. So it's just this mucus from your nose dripping down behind your throat that's causing irritation. You probably don't have AIDS." And so then he went to the doctor and told them the same thing, and then they diagnosed him with postnasal drip. So you just can't read a lot of it. Knowing your sources is the biggest thing. If you can put in like into a real symptom checker, some insurance companies or physician offices have like a symptom checker that actually like kind of helps you work through it.
I go to the
Um,
Mayo Clinic one. Is that reputable?
I think so. I think so. It does a pretty good job of like again, the Mayo Clinic is a large thing. It's not Wikipedia, it's not Google AI, it's not, you know what I mean, some other thing. Um, but there is a piece of the pit that demonstrates what Google can do with that. And I don't know if you've seen this episode. I haven't watched the whole thing. I watched a clip of it, and it's the measles episode where the kid comes in intubated with potential measles encephalopathy, and the mom is refusing an LP because Google says that it could have other repercussions. And that's the diagnostics for this disease process that would help them try to keep her son alive. And so it just sometimes the hive mind is not accurate. And so often, it causes unnecessary anxiety in your patients. It causes unnecessary visits to your doctor that could have been like a phone triage. Um, I think, again, this goes back. I'm going to go back to not having primary care because if you had primary care and you could see your doctor within 2 days, you might not live on Google trying to self diagnose and see if it's worth an $350 copay to go to the ER. Um, but yeah, I think that it causes so many more issues than it solves unless you have some either background medical knowledge or are really good at vetting your sources and figuring out what is and is not important. Because that's what, like when you said, I give you 8,000 pieces of information, I tell you too much, but literally I want you to tell me too much because you don't know which of those pieces of information, like house, you don't know which of those pieces is so important. You can tell me XYZ and then all of a sudden say, and then I was eating, you know, kiwi and it happened. And I'm like, oh, these gloves are latex. I shouldn't be touching you because I think you might have a kiwi allergy. Like there's just these other pieces that you don't know what's happening in my brain to help diagnose you.
Yeah,
So
and
it's
then
kind
it
of
seems like there's
interesting.
a certain type of person that just really wants to have the worst. I mean, like, there's forms of hypochondria where
Mhm.
it's like now I know I had a friend oh gosh, we're going over, but whatever. I had this friend that was a hypochondriac, and he would go to this was totally, unethical. I'm not gonna mention names, but he was like a
I don't
holistic,
know 'em.
nature path. I mean, the guy's probably dead by now. This is 40 years ago. But he told me one time on the side when we were drinking beer, it's like, "Yeah, your buddy, he comes in all the time with some ailment. I just give him sugar pills, and it clears it up." So he was just treating this
Mhm.
guy with placebos every time.
Placebo effect, placebo effect,
Yeah.
placebo effect.
Yeah, he
It's
probably crossed the line there telling me about it in a bar, but, there you go. We're all human. One thing the hive
you
mind
probably
does
did.
get right, and I wanna thank the hive mind because the hive mind brought me to you, Lexi, a friend of a friend, on my
They
Facebook.
did.
This is where I always find my consults for my novels, is like because there's, like, thousands of people I could ask, "Do you know somebody, with a big personality that is a ER nurse or whatever?" And so I'm really grateful that we got to talk to you today. I'm excited because this is a series I've been wanting to do is talk to people with, like, fascinating jobs, and, I'm glad to kick it off with you, and you've set the bar really high, and, I wanted to thank you, Lexi, for joining us today on A Fresh Face in
Yeah.
Hell.
Oh, it's awesome. Thank you so much for having me. I agree. This is the one of the good things that comes out of social media is never know where you're going to end up. So I appreciate it.